Hello, everyone, and welcome to today's webinar, Lessons from the Laboratory, Optimizing Your Tissue Processing. I am Marie Stone of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Leica Biosystems. To learn more, visit leicabiosystems.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar is educational and thus offers free continuing education credits. Please click on the Continuing Education Credits window at the bottom of the screen to obtain your credits. I'd like to now welcome our speaker, Robin Fitzl, Senior Field Applications Specialist, Leica Biosystems. Robin, you may now begin your presentation.
And thank you for that introduction. This webinar, entitled Tissue Processing Artifacts, will discuss how to optimize your tissue processing and recognize the cause of common artifacts. The learning objectives for this webinar are as follows. Discuss pre-analytics and the impact of improper fixation and artifacts on tissue processing. Discuss fixation and the impact of incomplete fixation on tissue processing. We're going to describe the impact of improper prosection, which is actually the dissection and sampling of tissue, and determine satisfactory processing of samples. Last but not least, we're going to explain why routine maintenance is a critical success factor to proper tissue processing. This slide has two examples of what the ideal sections in a perfect world would look like under the microscope. The skin section on the left is clean, with the eosin staining the components of the dermis with different shades. The colon section on the right is crisp and has well-defined nuclei. You can see some of the cells even contain mucin. There is no background staining or muddiness to the stain. This is a perfect example. One artifact seen in the lab that is not uncommon is crush artifact. You can see that the lung section on the left is architecturally preserved, while the section on the right has mild compression at the bottom center. The staining, although not ideal on the right, is okay, but you cannot see some of the alveolar sacs like you can on the left. The cause of this artifact could be maybe compressing too hard with blunt forceps. One way to optimize and to avoid this artifact is to exhibit care when handling these type of tissues. This is an example of mild artifact. A little bit more severe situation in this sample would be, as you can see again on the left, is an architecturally preserved section of lung, while on the right is a section of lung that has moderate crush artifact. In a severe example, you can see again on the left, we have a well-preserved section of lung, while on the right, near the top left corner, you can see that there is crush artifact that actually has caused nuclear streaming. An artifact that is commonly seen is cauterization. You can see a normal section of breast tissue on the left that shows connective tissue evenly staining, while on the right, the section, although it is lighter, near the top center is an area that is darker. If you were able to go down on higher power, the nuclear detail would either be absent or unclear. Cauterization oftentimes cannot be controlled in histology, as it is a part of the surgical resection procedure to remove the tissue, but it is good in this slide to at least recognize it. An artifact common in the research world are perfusion artifacts. I know that this is a technique that's vital to whole organ fixation in research and for optimal results. care must be taken to avoid architectural damage to the tissue. You can see here that the section on the left of lung shows the normal architecture, where on the right, the spaces are more open, more wide, that indicates there's been damage by perfusion. The next two slides will demonstrate the results of little or no fixation and result in degrees of autolysis. The section on the left is a beautiful section of kidney. Here you can see the glomerulus and Bowman's capsule, they components that are easily appreciated. In contrast, the kidney section on the right, where the architecture is preserved, but the cellular details are scant. This would be considered mild autolysis because there are areas where the nuclei can be seen. There's a little, you can still identify tubules, but it's not as nice as the section on the left. Here we have a nice section of liver on the left. You can see the hepatocytes with nuclei that have well-defined nuclei and sinusoids containing RBCs. While the section of liver on the right is an example of severe autolysis. The architecture is not only skewed, but there is little or no cellular detail. Let's move on to another artifact that deals with contamination. The next three slides will show examples of such. On this section of brain, you can see by the red arrow that it's been contaminated with plant material. On this slide, the section of lung has been contaminated with a section of liver tissue. Here we have a section of cardiac tissue contaminated with a small fragment of thyroid. To optimize all of these contaminant scenarios shown here in the last three slides, it is best to avoid these types by keeping the dissection tools one uses and the space where the dissection occurs clean. Formalin pigment is another artifact that occurs in the lab, and it is when formalin is not buffered. To optimize, it is ideal to either make up or purchase formalin that is buffered at a pH of 7.2. This is a section of bone that has been properly decalcified. Here you can see the detailed structures such as the compact bone, bone marrow, tuberculi, and the periosteum. Contrasting to that section is an under-decalcified section of bone that results in areas that are thicker and that stain darker. Of course, the opposite of under-decalcification is over-decalcification. Again, on the section on the left is even and well stained, and the structures are easily identified. On the right, you can see a section of bone that has been over-decalcified. Over-decalcification also can adversely affect your IHC, such as kappa and lambda, that would not work with this section. Be aware that decalcification solutions, whether they're purchased or they're formulated in the lab, are harsh, usually acidic. So monitoring the process of the time needed to get to the endpoint where you can get a section is necessary, but being mindful of that time is important so that you not only have good histology when it comes to H&E, but that your IHC results are good too. Let's turn the tables and have it be your turn. Can you tell me what can cause these type of artifacts? Let's discuss the first one. In the histology lab, when tissue is submitted for processing, the cassettes are designed to hold sections that are no more than 2.5 by 2 centimeters in length and in width. The thickness, though, should not exceed more than 3 millimeters. Here, the section appears to have the correct length and width, but the cross-hatching of the section indicates that the section was way too thick. The second artifact I showed you is due to sponges in the cassette that are sometimes necessary for tissue that is very small, or tissue samples that are mixed with blood or mucinous material. But sponges too can also cause artifacts that can be seen here. When we have appropriate fixation, the result is this beautiful section of colon. You can see that it again is clear. There is no background staining. There's no muddiness of the stain. The nuclei are well defined. All the structures here are clean and crisp. In order to get these type of sections that turn out great, as in the previous slides shown, one key ingredient is fixation. The standard rule for fixation is usually 20 parts of fixative to 1 part tissue, not the reverse, as you can see with this image. That clearly gives you an example of what not to do. Let's talk about zonal fixation. So you may have the right ratio of formalin to the specimen, but if you have hollow organs or large tissue resections, you want to make sure that the hollow organ is open and that a large specimen is prepped so that the fixation can occur throughout the specimen. This is a side view through uterus. So you can see that about the outer half has formalin fixation, but the endometrial canal also looks like there's a submucosal fibroid there, has a little bit too much red pink appearance to it, which indicates to me that not only has fixation not reached this area, but it also looks like it might have some beginnings of autolysis. When we look at it under the microscope, you can see here the section on the left it would be an example of good fixation. This is decent staining, where on the right, you can see there's already some breakdown of that gland. So we know that shrinkage occurs at every stage of processing, but the harshest by far, of course, is ethanol. Here is the result of tissue not being completely fixed by formalin and then being placed in alcohol. The sections on the left-hand side are examples of ideal liver and kidney, while on the right, these sections, the fixation step has been completed by alcohol. There is excessive shrinkage and hardness of the tissue, which makes it more difficult to section. And usually on the microtome, you might see thick and thin sections where you might end up on the slide with a thicker section than usual. Usually you're cutting anywhere from 3 to 5 microns. And so the stain is going to be heavier. Also here, and this is a whole nother subject, but when you have overfixation and overprocessing, you have the possible loss, of course, of bound water. This is an artifact of an example of buffered salts. This is an extreme example of the salts making it all the way through the processor to the paraffin block, but you can see by the red arrows scattered, actually this is on the left-hand side is numerous holes that indicate that buffered salts are in the tissue. This occurs when neutral buffered formalin, and usually the following alcohol is above 72, 73%. There is an acid-base reaction that causes the buffered salts to precipitate out. Going back to that beautiful section of colon, shows here again that it is clean and crisp. The nuclei are easily seen near the base of the cells. This is an idea of what we're looking at with appropriate dehydration. When tissue is over dehydrated, of course, shrinkage and loss of bound water can occur. The sections are then more difficult to cut and hydration with water is needed. These sections of bowel show chatter and some areas of darker staining. Take note that this section can represent more than one root cause. Remember, the section on the left is what we're going for. It has crisp staining with well-defined nuclei and cilia compared to the section on the right that is an example of severe overdehydration that not only results in chatter and darker staining, as we discussed in the previous slide, but also you can see these artifactual spaces. Here is that great section of bow that is evenly stained and structures well defined, contrasted to the one on the right that has been under dehydrated. Here you can see that the staining is murky, not well defined. That is because there is still free water present. Take note that this section can represent more than one root cause. Let's talk about appropriate clearing. Remember, this is the ideal section we want. The section is clean, crisp, evenly stained. Structures such as the nuclei are easily identified near the base of the cells. When tissue is overcleared, shrinkage and loss of bound water can also occur. That is because if xylene is used, it has a dehydrating characteristic much like alcohol. The sections again are then more difficult to cut and hydration might be needed. These sections, of course, show again chatter and some areas that are staining darker than they should. To minimize or even avoid overclearing, take in consideration not only how many steps of clearing that you have on your protocol, but also if there are temperatures on those steps that might be contributing to overclearing. Remember again that the section on the left is what we're going for. The section on the right is an example of overclearing that has not only resulted in chatter and dark staining, but also, again, those artifactual spaces. Again, if xylene is used, it has that dehydrating characteristic like alcohol. So the sections are more difficult to cut. They can show the chatter and areas of dark staining. So be mindful of the steps of your clearing. Again, here is that wonderful section of bow on the left compared to the section on the right that has been under cleared. This section looks familiar, right? You can see that the staining again is murky, not well defined, and that is because there is still probably some water still present. Remember, I'm showing some of these sections in duplicate because you can have the same appearance but different root causes. Let's talk about wax infiltration. Remember, again, this is what we're going for. A nice section of bow that is clear, no background staining, no murkiness, everything is well defined. Again, here's that great section of bow, just to show you the contrast of a section on the right that shows incomplete wax infiltration. You can see the section is murky, not well defined, and looks familiar to previous slides I've shown you. Again, you can have this appearance on the right, but have several root causes. To avoid or to optimize to avoid this artifact, taking in consideration of the paraffin infiltration times might need to be considered. Also, too, you always want to have vacuum on your paraffin steps to pull out any residual xylene that might be in the tissue section. Let's talk about maintenance. Recollect that this is the ideal section we want, right? It's clean, it's clear, it's crisp. We've talked about some of the details. But I've saved the best for last because this, unfortunately, is an area that's so often dismissed. Remember, optimal histology sections are what we're targeting, right? Do these seem familiar? Yes. That is because if proper maintenance is not performed, residual water, dehydrants, and clearance can cause this type of poor histology seen on the right. Even if you don't have enough paraffin stations or vacuum on your paraffin that leaves a little bit of residual xylene in the tissue, this is the result of that too. As a final suggestion, working with your field application specialists and performing regularly scheduled preventive maintenance could optimize these processes. Leica has 14 specialists across the United States and a technical support center as well in the Chicago area. Thank you so much for your time. And now we will move on to questions.
Thank you, Robin, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. So let's get started. Our first question is, what is the best ratio of formalin to tissue for optimal tissue processing results?
Thank you for that question. First of all, we want to be sure that your formalin is fresh and buffered at around 7.2 pH. Then, if you have a hollow organ, such as a uterus, bladder, any organ that is large, also like kidneys or liver, want to be sure that you prep that specimen according to your facility's protocols, so that the formalin can access every area of that specimen to ensure proper fixation.
All right, thank you. Next question. What are two examples of typical laboratory processes that can impact quality tissue processing?
I can think of a couple. I think the first thing that comes to mind, it is a common practice that we see in the laboratory, where if the tissue cassette is 3 by 2.5 by 0.5 centimeters in dimensions, which is standard, right? For some reason, the person submitting tissue thinks that all of that is their real estate, and it's not. We need to leave at least a half a centimeter along the width and the length of the specimen so that fluid can flow through. Also, too, we talked about in the presentation, if a specimen is over 3 or 4 millimeters in thickness, then you're compressing the tissue down when you shut the lid, and then restricting access of the fluids to process the tissue. The other one I can think of, I think it's common in the life science arena, is to only have maybe 1 or 2 protocols. And if you are sharing a core facility, different projects might entail different species of to be studied. And with that, I think comes the consideration of customizing your protocols. For example, I know that tissue that may be small is not going to require an 8-hour, 12-hour run, where organs that are large, especially like fatty tissues, are going to require much more time. So customizing those protocols too. I think those are 2 important factors to consider.
Thank you.
You bet.
Next question. What are a few possible causes of reagent artifact resulting in poor tissue processing?
I think the number one thing that comes to mind, and I saved it to the last of my presentation, and it's the most common thing that I see in the field, is maintenance. Changing the reagents, checking the reagents. If you're making formalin up in the laboratory, checking the pH. I think it's all around the integrity of those reagents that you're using. That's the number one the issue that I see in the field, and that I'm having to talk to people about, is not only fresh reagents, but having a schedule there that is a regular, either depending on the volume of tissue that you're processing, determines on how often you're going to change reagents.
Right. Next question. What is the single most important step to ensure that optimal tissue processing takes place within the chosen platform every time?
Oh, I think if I knew the answer to that, I would be retired. That's a great question. I think I can speak to maybe a couple of things. I think it's a 2-part question. The first part is pre-analytics. Pre-analytics is such an important arena to really consider when you are getting ready to process tissue, making sure that it's fixed, making sure you're not, overfilling the cassettes. Simple things to think about, but so often overlooked. I think with the second part too, when it's on the processor and you've done your validations, you have fresh reagents. I think again, it's key to the maintenance.
Thank you.
Thank you for that question.
Next question. How do you overcome zonal fixation?
Again, yeah, any organ that's considered large, I have to try to give some type of reference. So, probably if you're going to do tissue processing on mouse or rat brain, you definitely probably going to use maybe a perfusion technique. I don't know. I don't originally come from the life science background. My experience is only in clinical. But I've been with Leica for 12 years, so I've learned a lot in the life science arena. But if you are not going to perfuse, then definitely you want to bivalve or open hollow organs, at least pierce them and and especially even small specimens like lymph nodes, they have that kind of pseudo capsule on the outside. You want to pierce those so that formalin fixation can get in that tissue and do all those covalent bonding it needs to do.
Thank you.
You bet.
Next question. How should I approach fixing chatter on glass slides?
Oh, I I don't know that you can. Um, the architectural damage has been done. I am not aware of being able to undo it. There are some things that we can do when it comes to processing, but it usually deals with under processing, not over processing.
All right. Thank you. Next question. What would be an effective way to decalcify arteries?
Make sure that you have plenty of fixation. The standard fixation time uh, in the research arena, I know, is usually around 24 to 48 hours. And all of the research folks are great about moving that tissue out of fixation into 70%. But once you're confident that it's fixed, then you can either place the tissue before processing. It depends on the degree of calcification too. If it's just mild, you can go ahead and process the tissue. And then once you cut into the block, when it's in paraffin, you can just do a face decal to try to get that section. But if it's a little severe, then you definitely want to do the decalcification after you've done your fixation. Be sure and rinse it.
All right. Thank you.
hmm
Next question. Are there artifacts specific to the brain?
Oh, I would have to think about that.
Yeah. This is one you can answer via email.
I think that would
All
be
of
a
the
great,
questions.
because I'm not sure exactly. Yeah, I would need to know a little bit more information. Nothing comes to my mind off the top
Okay.
of my head. Yeah, off the top of my brain. Ha ha.
All right. um, Next question. Would you please explain what perfusion is?
Oh, from my understanding, perfusion is a technique where it uses tubing. So for like lung, you want to move fixation through the specimen. You would place a tube that moves the tissue, moves the fluid in, and another tube. Usually, they're using the an artery and a vein to move fluid in and move it out. So it just kind of I'm trying to think of the best term. Moves the it perfuses, right? It's accessing and maintaining the whole organ without dissecting it yet.
Okay.
I think it's common in brain, large organs, lung, like that.
Yeah. All right. Next question. Would you use vacuum on your fixation, ethanol and xylene steps, or just your wax embedding steps?
Um, there's no there's no codified method of how we do our processing protocols. Traditionally, in when at least as far back as the 80s, I can remember that we did pressure and vacuum on every step because it was a necessary catalyst for tissue processing. We always want to have vacuum on your paraffin because you want to pull out that little bit of xylene that's going to be trying to stay in the tissue. But you can use It's common to see pressure and vacuum on some processors. I have seen runs that don't have anything on them until they get to paraffin. So it's about what works for you and your laboratory and your tissue. Every lab I have found in the last 12 years with Leica is unique and does things a little bit different in the way they process and the way they establish protocols. But if it's validated and it's working all the way down even to your advanced staining, then that's great.
Great. Thank you.
Mm-hmm.
Next question. Uh, some why would paraffin crumble when cutting? Is it due to humidity or because of the embedding reason?
Probably, I don't know that humidity would be a factor, but if it's crumbling, sometimes it depends. I think we have to establish first, is the paraffin still, the integrity still been maintained? If you want to make sure that it doesn't get too hot, you want to make sure that I know that sometimes with maintenance, people tend to delay the time, the schedule of when they change it. You can get an oversaturation of paraffin, but it would have a really soft, greasy feel to it. With crumbling, the first thing that comes to my mind is when you're sitting at the microtome and you're using some type of freeze spray to get it cold, because we do have to have it cool to get a section, especially if you're cutting, down to 2 microns. It can be difficult in a warm room. But if you're spraying it too much, it definitely will crumble. Sometimes people will think they can put paraffin in the freezer, and certainly with a -80, you don't want to do that because it will crumble.
Okay.
Mm-hmm.
Thank you.
You bet.
Next question. What's the best fixative for breast tissue?
I think I can speak to what the standard fixative is for breast tissue. Um, Neutral buffered formalin as most of you know, has been around for a long time and is the standard fixation. I think optimizing that breast tissue for studies that follow is what's really key. Following, if you're especially in a clinical setting, it's different than if you're in a life science arena. But if you read any textbooks or literature, 24 to 48 is ideal, um, and that certainly is uh, different requirements when it's research versus clinical setting.
All right, thank you. Next question. How long can processed tissue sit out before it's embedded?
Oh, I love this question because I think that I've been a histologist for over 40 years, and I think we never really thought about this type of question. We didn't, for the most part, tissue histology can be pretty forgiving. But we have found with the introduction of molecular testing in histology that we have to be a little bit more aware of what we're doing in the laboratory. And this is a great question because it actually addresses this. Um, Once it's processed, and I don't know, this is my opinion or what I've talked to other techs about and their experience, is that the tissue, once it's processed, is processed. So if you feel like the embedding is going to be delayed, then there's not a problem leaving it out. I think the critical component is ensuring that when you are ready to embed your tissue, you want to be sure that it comes back up to the temp of your embedding center. So it just can't be the cassette just can't be warm, but you want to make sure your tissue is warm all the way through, right? Because if you embed it and the tissue is slightly cooler, then you may not get the melding of the paraffin to the tissue, and then you can have trouble sectioning. On the flip side of that, well processed tissue can be great, right? It's ready for everything downstream. But I have walked into laboratories where cassettes that were processed have been left on the embedder for not only hours, but I had a lab tell me they left it in the embedder for about a week.
Oh,
Well, the temperature is high, and that long-term exposure to that temperature eventually affected their IHC, especially sensitive markers like nuclear markers. So that's a great question. Love that
interesting.
question.
Interesting.
Mm-hmm.
All right, next question. We are always getting understained hematoxylene in histopathology staining. We are using Harris hematoxylene followed by bluing, and I think that's supposed to be destaining. Can any
Mm.
steps of tissue processing result this problem, though eosin staining and tissue morphology are fine?
Ah, this is a great question, and one I would definitely want to ask a few more questions about. Telling me that your eosin staining is fine, but not the front end of your hematoxylin staining tells me it might be an issue with your stain line and not your tissue processing. But I would need to look at a slide and talk to you about the steps. Some of the common problems with hematoxylin staining is once you clean it up with usually we have a little diluted acid rinse after water, and then we're going into the bluing. But it depends how fresh your hematoxylin is, right? How much time you have on that. And if you are cleaning it up because it is a regressive stain and you use a diluted acid to kind of clean it up, is that too strong, right? So, but
All right.
again, you'd have to look at the slide to be sure.
Okay, thank you.
You bet.
Next question. How critical is it to utilize the warm water flush program on your tissue processor? If so, how often should you be using the flush program?
Ah, good question. Um, this is uh, this is uh, not present on all processors, right? But there are some instruments out there that do require water flush. The reason, let me give you a little background on why we do warm water flushes, and it refers back to the slide we talked about with formalin salts. So if through processing, as formalin moves from the formalin to that first alcohol, if it's a little too high, I think I mentioned the 72, 73, it seems like that's when it begins. You're going to have those buffered salts coming out because of that acid-base reaction. So that's why at the end, we actually do during our maintenance in the clean cycle, we do the warm water flushes, and that's to keep those salts out of the instrument, right? It's more to keep it, number one, out of the tissue, but also to keep the instrument clean of those salts. So I know that at the end of a clean cycle with some instrumentation, it's automatically there. It usually goes through a clearant, a dehydrant, and then a water step. If you have those type of instruments set up like that. So it depends on how often you're using the instrument, and it depends on your maintenance schedule.
Next question. Uh, what do you exactly mean by chatter?
Oh, sure. Chatter is when the tissue is, of course, having difficulty on the microtome, and it's dry for one reason or another. And another, I think, term we use is Venetian blinds, if that helps. So if you lowered your Venetian blinds and opened them a little bit, you can, right? You have it's kind of a thick, thin step. So you'll have a band that's darker, then a band that's lighter right above it, and it just follows repeatedly after that. And that's what we consider chatter because the section is not even. It's not going to be that nice 4 to 5 microns all the way across. And that's when you get the light and dark staining alternating. And that's what we call chatter. And that's usually over processed.
Interesting. Thank you.
You're welcome.
Next question. Will overfixed specimens affect IHC staining?
Yes. That is why we follow recommendations of a maximum time. If you're doing IHC, you're doing formalin fixation, usually you're going to do some type of antigen retrieval, and that's what remedies because those covalent bonds are so many when you have properly fixed tissue, where you want to be able to expose those sites that you're targeting for advanced staining.
Next question. Can the crush artifact come from a tech pressing down on a tissue too hard with forceps during embedding?
Absolutely. Yes, care must be taken not only at the board where they're prosecting, but all the way down um, to the embedding. Yes, good, great question.
Right. Next question. Can paraffin expire? And if so, can it be used if it's expired?
I do know that when you purchase paraffin, it does have an expiration date. Um, I would not. I don't. Paraffins come in all different type of flavors, right? And it's all about the polymers that they put in paraffin. So if it was expired, I don't. I think I would try not to use. I would not use that paraffin. I think long term, as you move down and begin to use it, not only would it not process properly, but at sectioning, I think it would make it difficult also.
All right. Thank you. Next question. How long must tissue remain in a fixative and still be good for processing?
Ah, good question. I believe what I've seen in the laboratory, of course, it's different life science versus clinical. A lot of times we're required in clinical to hold it for a minimum amount of time, where I'm not sure in life science what the regulations are there. But when tissue is fixed, like we talked about the 24 to 48 window when you do your pre-analytical steps, uh, it's moved in the life science rate. It's usually moved what I've seen from formalin to a 70% alcohol, which holds it for quite a long time. I don't know what the endpoint would be to that.
Thank you.
Mhm.
Next question. How long how long can tissue be kept in neutral buffered formalin before tissue processing for histopathology?
I think that's a repeat of the last question again, too. Um, it depends if you're in the clinical or life science arena. There are restrictions here in the United States in regards to certain specimens about formalin fixation, but I think if as long as you're keeping that 24 to 48-hour window, you're good.
All right. Thank you.
Mhm.
And we will wrap up with that question. Thank you, Robin. Do you have any final comments for our audience?
I don't. I don't think. Well, I would like to thank everybody for taking the time to be on. Certainly reach out if you have any more questions. We'll certainly try to get you some information that would help your tissue processing.
Thank you again, Robin, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Leica Biosystems, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone, and goodbye.